Yeah. So I shall be talking about some of my innovations in DMEC surgery. I have no financial interest. Now, currently, DMEC is the preferred technique of endothelial keratoplasty among corneal surgeons worldwide. It results in faster visual recovery with minimal refractive shift and lower risk of endothelial rejection. The common barriers to uptake of DMEC among surgeons transitioning to this technique are the anxiety related to incorrect insertion of the donor tissue and the anxiety related to tissue preparation. In the West, you have the eye banks that pre-strip the donor, or you have the patient-ready DMEC donor. At least in our part of the world, surgeons have to strip their own donor tissue, and there is a learning curve of this process as well. In the learning curve, tissue loss rate may vary between 2 to 20%, and it results in cancellation of surgery, another expense for a second tissue whenever the next surgery is scheduled. This is an illuminated punch block that I designed, available from Coronet, and this was published in IGEO. So in this device, it basically provides retroillumination. So when you are preparing your donor tissue, you are able to see the Decimus membrane very clearly, and thereby if you have any radial tears or horseshoe tears, you can identify them much earlier and thereby prevent any loss of tissue from unrecoverable damage. You can see the difference in contrast between the conventional and the illuminated Trifine. In terms of insertion, there are various inserters made of either plastic or glass. The basic principle is a fluid-based injection. As you inject the BSS into the anterior chamber. Often it results in increase in the anterior chamber depth, and depending on the volume, there is rise in the intraocular pressure. And if the chamber becomes very deep, the donor scroll has larger space to move, so thereby the orientation can shift. And if the wound is not tight, it's leaky, you can have leakage of fluid from the anterior chamber, from the main port or from the side port, and there can be risk of donor expulsion as the donor tissue is inserted. Once inserted, it can go into any of these configurations, and then you have to do various maneuvers to get it into the right configuration and then open it up. The preferred configuration is a double scroll configuration. So we published our technique where we tried to modify some of the technique. One is whether we can achieve a donor scroll configuration in most of the cases. So here, when you load the tissue into the wider portion of the glass injector, you agitate the fluid by a to and fro movement of the fluid. So as you push the fluid, the scroll opens up, and then when it re-scrolls, it can go into a double scroll configuration. So we found that in out of 20 eyes, we could achieve that in almost 85% of the eyes. The other thing is that if you have an inserter with a smaller tip, it results in a faster uncontrolled delivery, and often the donor orientation is lost. And if you have an inserter with a wider inserter tip, you can have a slower controlled delivery with the maintenance of the orientation, but often the AC gets filled with fluid and you have a partial delivery of the donor into the anterior chamber. To overcome this, we propose this concept. You connect the AC maintainer, the flow is on, you insert the tip of the inserter into the anterior chamber, then you rotate the tip so that the DM scroll is facing upwards. Once that is done, you stop the flow in the anterior chamber maintainer and disconnect it from the IV tubing. Now the AC maintainer acts as a conduit for fluid to flow out from the anterior chamber. This is seen in this. You see that we are injecting trypan glue into the anterior chamber, and that trypan glue flows out of the AC maintainer tubing. Now, during surgery, when you do that, as you are inserting the donor, there is no back pressure from the fluid in the anterior chamber. So there is no tendency for the tissue to rush out of the anterior chamber. As the anterior chamber does not become very deep, the orientation of the donor scroll is maintained, which results in easy unfolding as the orientation of the scroll is often in the correct position. So in our series, we were able to unfold the tissue in less than 4 minutes in all eyes, and the donor tissue, the endothelial cell loss was also minimal at 16% at 6 months. If you have the intra-op OCT, this is definitely useful. It can give you in real time the idea about the orientation of the donor tissue. The other thing about the training part is we prepared a donor model which can simulate the human eye when you are practicing the DMEC surgery. So you use a latex diaphragm on the base of the artificial chamber, which behaves like the lens iris diaphragm, so that when you insert the donor tissue into the anterior chamber, by aspirating fluid or injecting fluid within the tubing of the AC maintainer, you can shallow or deepen the anterior chamber. So that gives almost like a real feel to practice the DMEC surgery. This is useful because for the learning surgeon, they can use this to master the technique before they go on to doing surgery for the patients. So this is a short video which shows you once you make that, the donor tissue can be inserted. Finally, in conclusion, all these 4 steps of donor preparation, donor insertion, unfolding, and the practice model for DMEC, these are some of the innovative techniques which can simplify the DMEC surgery. Thank you. Thank you.